Thomas Reeves was 58 years old and had never thought about his own legs. They simply worked. 30 years building houses in Dallas, Texas, climbing scaffolding, carrying materials. Thomas's legs were work tools, strong, reliable, with no relevant medical history. He didn't think about them the same way he didn't think about his lungs when he breathed. In 2019, after a mild coronary event that led him to a cardiologist for the first time in his life, Thomas left the appointment with 3 new prescriptions. One of them was atorvastatin 40 milligrams. The doctor had said it was for cholesterol, that it reduced the risk of another cardiac event, that practically everyone with a cardiovascular history took it. Thomas took it, every day, without fail. In 2020, his legs began to ache after long days on the construction site. He attributed it to the hard work, his age, the Dallas winter. In 2021, the pain appeared at the beginning of his shift. In 2022, Thomas could no longer climb the scaffolding. In March 2022, a neurologist looked at the results of Thomas's muscle biopsy and used a word Thomas had never heard before. Myopathy. The muscles in Thomas's legs were being destroyed, fiber by fiber, silently, since 2019, by the drug that had saved his heart. Statins don't give warning when they decide to attack the muscle. They don't produce immediate pain. They don't inflame anything that shows up in a routine blood test in the first few months, because the marker that reveals muscle damage, creatine kinase, only rises detectably when the process has been underway long enough to be significant. Atorvastatin, like all high-potency statins, inhibits the enzyme HMG-CoA reductase, the rate-limiting step in cholesterol synthesis in the liver. This is what lowers LDL. This is what protects the heart. It's the mechanism by which 26 million Americans take statins every day with documented and positive cardiovascular outcomes. The problem is that the same metabolic pathway that produces cholesterol also produces coenzyme Q10, a molecule essential for the electron transport chain within the mitochondria of all cells in the body, including muscle cells. Without sufficient coenzyme Q10, the mitochondria cannot efficiently produce ATP. Without ATP, the muscle cell cannot contract, recover, or remain structurally intact. Over time, it begins to degenerate. In simpler terms, statins, by blocking cholesterol synthesis, simultaneously block coenzyme Q10 synthesis. And this depletion, in a fraction of users with a specific genetic predisposition, variants in the SLCO1B1, COQ2, and CYP3A5 genes, produces progressive myopathy ranging from mild muscle pain to rhabdomyolysis, the massive and potentially fatal destruction of skeletal muscle tissue. Thomas had the SLCO1B1 variant, which reduces hepatic statin transport and increases its plasma concentration. No one had done this test before prescribing atorvastatin 40 milligrams. Because the pharmacogenomic genetic test for statins is not in the standard American cardiovascular prescribing protocol. It is a test that exists. That costs between $100 and $250. That can be done only once in a lifetime. And that, if it had been done on Thomas before 2019, would have changed the choice of statin, the dose, or the muscle monitoring regimen that could have detected the damage before it became irreversible. What the FDA data on documented statin adverse events between 2003 and 2023 reveal about the proportion of users who develop clinically significant myopathy without the prescribing physician connecting the symptom to the medication will change how you understand the phrase rare side effect. But the mechanism by which coenzyme Q10 depletion progressively destroys muscle fibers is the detail that no doctor's office conversation communicates with the specificity it should, and that most physicians who renew statin prescriptions annually do not actively monitor. In October 2021, Thomas went to his general practitioner complaining of muscle pain in his thighs and calves that had progressively worsened over 18 months. The doctor ordered a serum creatine kinase test. The result came back at 847 IU per liter, above the upper limit of normal of 200, but not at the level of 3,000 to 10,000 that characterizes severe myopathy or rhabdomyolysis. The doctor documented in the medical record slight elevation of CK, context of intense physical activity, advised reducing exertion, repeat in 60 days. Thomas did not have intense physical activity. He had pain at rest. There were 2 options in that office. The first was to repeat the test in 60 days without modifying the medication protocol, which was chosen. The second option was to connect the elevated CK to the use of atorvastatin 40 milligrams, which had been listed in the medical record since 2019, and immediately consider dose reduction, switching to a lower potency statin, or adding coenzyme Q10 supplementation while further investigation was conducted. The second option would require the physician to have been trained to consider statins as a cause of myopathy in a patient with progressive muscle pain, and that the electronic medical record system had an automatic alert connecting elevated CK to statin use in the same patient. There was no alert. The physician did not connect the dots. The prescription was renewed. 60 days later, Thomas's creatine kinase was 2,340 IU per liter. He could no longer work. Statin-induced myopathy is not fiction. It is a documented spectrum ranging from simple myalgia, muscle pain without structural damage, to myositis, with measurable structural damage, to rhabdomyolysis, with massive destruction of muscle fibers that releases myoglobin into the bloodstream in sufficient concentration to cause acute kidney failure. In 2014, researchers at the University of California, San Diego, led by Dr. Beatrice Guillaume, published an analysis in JAMA Internal Medicine of 482 adults participating in the STOMP study, the largest randomized, placebo-controlled clinical trial on the muscle effects of statins ever conducted. The results were the first to demonstrate, using a double-blind methodology, that statin users experienced a measurable reduction in muscle strength and increased fatigue compared to placebo even in users who did not report pain. The damage was happening before the symptom appeared. The muscle was weakening before Thomas knew something was wrong. In 2022, a meta-analysis of 23 studies published in the European Heart Journal by researchers at the London School of Hygiene and Tropical Medicine documented that approximately 7% to 29% of users of high-intensity statins, such as atorvastatin 40 mg or 80 mg, develop some form of muscle impairment over the course of chronic use. In users with identified risk, genetic variants in the SLCO1b1 gene, this proportion rises to between 18% and 60%, depending on the statin and the dose. 7% of the minimum 26 million Americans on high-intensity statins are approximately 1,800,000 people, with some degree of muscle impairment, taking the heart medication that was prescribed with the best clinical intentions in the world. And most without knowing that the medication has anything to do with the leg pain they are attributing to age, hard work, winter, anything that makes more sense than the pill the cardiologist said was to live longer. The Thomas Reeves paradox was not in the statin. Atorvastatin did exactly what it was supposed to do for the heart. Thomas's LDL dropped from 18.7 to 62 milligrams per deciliter. He did not have a second coronary event. The statin worked perfectly for the organ it was treating. The instinct to protect Thomas's heart after the 2019 event with the most potent statin available, atorvastatin, 40 milligrams, without testing for the genetic predisposition that would triple his plasma concentration of the drug, and without establishing muscle monitoring with semiannual creatine kinase, created the mechanism that in 3 years transformed a construction worker who climbed scaffolding into a man who cannot climb a ladder. There was no medical negligence in the conventional legal sense. The cardiologist prescribed within the standard protocol. The general practitioner interpreted the CK elevation within the usual parameters. Neither of them did anything technically wrong according to the guidelines in force in 2019. The problem is that the 2019 guidelines did not include routine pharmacogenomics before prescribing statins. They did not include mandatory semiannual CK monitoring in symptomatic patients. They did not include automatic chart alerts connecting CK elevation to statin use in the same patient. The protocol was built for the heart. Thomas's legs were not in the protocol. What American medicine learned from Thomas Reeves, from the STOMP study data, from the London School of Hygiene meta-analysis, and from the millions of statin users who develop muscle impairment without anyone connecting the dots, is that statin pharmacogenomics is an available, validated, relatively inexpensive, and systematically underutilized tool at the time of prescribing one of the most widely used drug classes in the United States. What Thomas never recovered was the ability to do the work he had done for 30 years. The myopathy was diagnosed too late for complete reversal. Atorvastatin was switched to low-dose rosuvastatin with rigorous monitoring. The pain improved by 70%. The muscle fibers that were destroyed in the previous 3 years did not return. Thomas works as a supervisor now. He no longer climbs the scaffolding, not because he doesn't want to, because the muscle that would need to support the weight no longer does. His heart works perfectly. His legs paid the price. The protocol saved the heart. It forgot the legs. The difference between statin use that protects the heart without destroying muscle and use that produces irreversible progressive myopathy is not the cardiovascular diagnosis. It is not the severity of the risk, and it is not the need for treatment. It is a once-in-a-lifetime pharmacogenomic genetic test that identifies risk variants before the first pill and that changes the choice of molecule, dose, or monitoring protocol before the damage begins. If you take high-intensity statins, atorvastatin 40 milligrams or 80 milligrams, rosuvastatin 20 milligrams or 40 milligrams, and have experienced persistent muscle pain, leg weakness, or fatigue that did not exist before the medication, ask your doctor, has my creatine kinase been measured since I started statins? If the answer is no, ask for the test today. And if you haven't started statins yet and have a family history of muscle or kidney problems, ask if statin pharmacogenomics makes sense before choosing the molecule and dose. The test exists. The knowledge exists. The protocol hasn't yet reached the doctor's office in a systematic way, but the question you ask can arrive before the damage begins. Thomas asked the question 3 years later, when the answer still mattered, but the muscle could no longer hear. But statins aren't the only widely prescribed cardiovascular medication that produces organ damage distant from the therapeutic target without routine monitoring. In the next video, the anticoagulants that 42 million Americans take to prevent stroke, and the silent brain hemorrhage that a fraction of them develop without symptoms until the neurological damage is already extensive. The name of the event is anticoagulant-induced intracranial hemorrhage. The interval between the start of use and diagnosis can be measured in years, and the INR that should protect may be the number that failed.